Welcome everyone, and thank you for joining us today for our informational webinar to kick off our Opioid Guardianship Project Take 2. A couple of housekeeping things. Please mute all of your lines so that we do not have background noise during the call. We will also mute you from our computer here in just a moment. If you do have any questions, please feel free to use your chat function, which will be on your bar on your little Zoom area. So please use that to ask any questions that you may have throughout the program. And then we will get to those either at the end or we'll try to answer them as we go through. Again, thank you for joining us for our Opioid Guardianship Project Take 2 informational webinar. Jennifer and I are extremely excited to kick off this second cohort as we saw some great success with our first cohort. My name is Sarah Durr, and I am the pharmacist here on staff as the Medication Management Lead at the Iowa Healthcare Collaborative with the Compass HIIN. And I also have Jennifer Kriegmer with me, who is a nurse on our staff who serves as a Quality Improvement Advisor, and she has been really leading a lot of this work within the HIIN as well. And with that, we'll go ahead and get started. Okay. So some of you may have heard this story before, but we wanted to start off with really our purpose around the Opioid Guardianship Project right now. And what we're looking at is moving upstream to prevention and intervention. So the story goes like this. There were 3 fishermen fishing at a river, and as they were there fishing, they noticed a child floating down the river. The first fisherman jumped in to save the child and pulled the child ashore. Well, next thing they know, there were multiple children coming down the river. So the second fisherman grabbed a boat and went out and got the children into the boat to try to save more at a time. As they were doing this, the third fisherman ran upstream, and the other 2 got a little upset with him, wondering where he was going. Well, the third fisherman was running upstream to see where the children were falling in so that he could repair the bridge where they were falling in and prevent them from actually falling into the stream in the first place. So what this really does with our opioid guardianship program is it reframes the way we're looking at opioid and pain management. And instead of being reactive and trying to fight addiction first and fight that opioid use disorder, we are starting with actually preventing opioid addiction from happening in the first place. Looking at different prescribing habits, looking at how we frame pain, and we'll talk a little bit more about that today. Well, why are we here? What are we here to achieve? Really, the purpose of our second cohort is to reframe the expectations that healthcare professionals, patients, caregivers, and our community look at the utilization of opioids and how we use comfort resources to individualize treatment plans and reduce the number of opioids that are prescribed for acute pain. Who does this really involve? It's going to include any hospital-based community leaders, and this includes our patients, families and communities, providers, pharmacists, quality professionals, nurses, clinics, long-term care, case managers, dentists, veterinarians, law enforcement, and EMS. We may have missed a few in there, but it's really anyone who touches the patient within the hospital setting and is related to medications or the use of opioids. Again, we are looking at this from a 3-pillar approach to actually combat the opioid crisis and reduce adverse drug events here in Iowa. And our first one, like we are talking about today, is that upstream prevention and appropriate prescribing. Once we get a good handle on this, we'll move more into that addiction treatment and how do we prevent relapse. And then we will look at diversion prevention and how we do proper medication disposal. So keep those 3 pillars in mind as we step through this project and know that we are starting from the upstream side of things.
Okay, so we're going to go through our benefits of participating now. Okay, our first one here is to educate healthcare providers on evidence-based best practices and emerging new resources. As Sarah and I look through everything, I feel like something new pops up every day. There's lots of education around and lots of information. So we'll do our best to make sure that you're receiving everything as it comes out and it'll be fresh to your eyes first. We do have a resource flyer that provides controlled substance disposal sites, treatment centers, and Naloxone standing order participating locations. We do get that information with the Iowa Board of Pharmacy and also with Iowa Pharmacy Association. So we do partner with them to make sure that information is correct for you and your patients. Another benefit is sharing of successes, interventions, and best practices with peer support in developing opioid treatment plans. We learned this in our first group that went through that we really have to pull together and do this together, because everybody, if everybody's working on the same thing, that's really a waste of resources and time, and when we work together, that's best. We'll have virtual coaching from expert pharmacists and quality improvement consultants. We'll have data analysis that will be provided by the Iowa Healthcare Collaborative. We'll have multidisciplinary, evidence-based best practices and emerging new resources that will be provided. You'll have the ability to participate in a comfort research study to show the efficacy of the comfort scale, and then also national recognition. So I'm going to turn it back to Sarah to set the stage.
So really what we want to do to set the stage of why we're doing this project is first take a look at the opioid timeline and how we got to where we are today. So in the 1950s and 1970s, we had oxycodone really become widely available. We also saw the World Health Organization dismiss the belief that morphine was actually addictive, and it was not just the World Health Organization that did this. There were multiple other associations and healthcare-related groups that also bought into this belief. We also had the Controlled Substance Act passed, and there was some war on drugs happening at that time on the illegal side of drugs. In the 1980s, we really saw this opioid phobia where physicians were scared to prescribe. They didn't know a lot about opioids and weren't quite sure how to use them yet. But then we saw some exploration of using prescription opioids to treat pain, which was not just due to terminal illness. So we started to see that happen. In the 1990s, it was said that there's an undertreatment of pain happening and a successful lobby at the legislature for an increased use of opioids. Additionally, physicians were expanding some of their treatment of pain with new opioids that were coming to the market, so there were more available. We also saw the marketing efforts of healthcare providers by pharmaceutical companies. So they were getting recruited to say, you should be using these medications, they're safe, they work, and there's not an addiction associated with it. Then we move into the 2000s, and that's really where we saw pain as the fifth vital sign and physicians being told they were under-prescribing pain medications and they needed to better treat pain. We saw an increase in opioids being prescribed, and we also saw the misuse and abuse of opioids quadrupling from 1999 to 2008. Lastly, we saw some research begin to find abuse deterrent formulations needed for medication. And the reason I go through this timeline, and if you go to this website, there's a more in-depth timeline before the 1950s even. But really this timeline shows that this is a healthcare created problem. It's not just on the physician. It's not just on the pharmacist. It's not just on quality and how we're looking at that. It's not just on how we do surveys, not just the pharmaceutical care companies. It's truly every single entity that has touched opioids and has had some of these beliefs is what has caused this to spiral. And now it's our turn as healthcare professionals to take this back and make sure that we change the way that we're looking at pain so that we don't have this continue to spiral as we move forward. Another thing that we like to highlight is the illegal drug deaths that are actually occurring across the United States. And this is from 1999 to 2014, so it is a little bit older data, but the most recent we were able to find. So the CDC actually released this in 2015. But you can see from that purple line where opioids are increasing quite rapidly, that's just the opioids that are actually being prescribed. Then you look, are being used in the US. Then you look at that orange line, and that's where we start to see heroin increase. Heroin is considered a narcotic, and so we'll talk a little bit about why people are going from prescribed opioids to heroin in a slide shortly here. But I think it is staggering to see that with the increase in opioids being used, we're also seeing an increase in the amount of heroin that is currently being used. So like I said, why are people going from prescription opioids to the use of heroin? This slide really highlights why this is happening. So you may have a lady come in who has some back pain, or she's having hip pain, or she had a surgery, and she's taking some hydrocodone for that pain to help relieve that, maybe taking it every 4 to 6 hours or so. Well, her pain continues and it continues to get worse. So then she goes back in and her doctor gives her some oxycodone to take, again, that every 4 to 6 hours to help with her pain. From there, she continues to have pain and moves into taking Oxycontin twice a day, as well as using oxycodone for that breakthrough pain. So she's taking a lot more opioid and trying to utilize the long-acting ones to actually help with that. Well, now at this point, she may go back in and say, you know, my pain is still really bad, and I think I need something more to help with this. And the physician may say, we're at this point where we're maxed out on our opioids. So she may then go to the streets or a friend or whoever to try to buy some of these medications. And Oxycontin in 2014 was actually selling for about $80 a tablet. The last I saw, it's over $100 currently in the United States on average, whereas oxycodone is going about $50 to $70 a tablet currently. So if we're looking at that, she could be spending hundreds of dollars a day to just help her with her dependence on opioids and help her manage her pain. She may not even realize that she has some addiction or opioid use disorder occurring. So at that point, when she can't afford this, it's much, much cheaper to go out and buy a bag of heroin for $15 a bag. So just going to get that might last her a couple of days. That might last her a week, just depending on how severe her opioid use disorder is. So that's really how it's easy for these patients to go from having a prescription medication and going into using an illegal substance just to help manage their pain. This is a really fascinating figure from the Board of Pharmacy last year, and this shows the number of controlled substances dispensed in 2016. As you can see from that darker purple section, hydrocodone was one of the highest controlled substances dispensed in 2016 here in Iowa. Looking at other things, we have other substances is also high. However, you can see things like lorazepam or clonazepam are also quite high, with still that hydrocodone being the highest on this graph. So that's also concerning to me as a pharmacist, thinking about the potential for drug interactions that may be happening with the number alone that are being prescribed in the United States or in Iowa currently. I also just wanted to touch on controlled substance dispensed in 2016 and looking at the mandates with the PMP. So really looking at mandating with PMP, you can see across the United States, there are some states that actually require prescribers in one or more professional categories to register with the PMP, and that's those states in kind of that light blue color. Those states that are starred actually require pharmacists or dispensers in general to register with the PMP. This data is from 2017, so it is our most current, and you can see that Iowa does not have either of these requirements. All pharmacists who dispense controlled substances are required to report that within a week of dispensing that controlled substance. So that is reported to the PMP through that, but otherwise we do not have any mandates around this. I know that in the legislature this year, we will have some things come forward around mandating the use of the PMP and even making this more real time as the Board of Pharmacy is updating our prescription monitoring program in 2018. So this may be something that we'll see happening with pharmacists reporting what's dispensed on a daily basis rather than on a weekly basis. So keep your eyes peeled on the legislature this year. We here at the Iowa Healthcare Collaborative truly believe that we have a great program here and a project that's going to help us move forward, that we may not need to mandate the use, but rather people will start using the prescription monitoring program because they are doing the right thing and they're doing what's right for their patient. So with the Compass HIIN, we really do hit 3 different states. We hit Iowa, South Dakota, and Illinois. We have hospitals throughout that area. The Iowa Healthcare Collaborative is our main home for the HIIN, but then we also partner with the South Dakota Association of Healthcare Organizations. Currently, we have 153 hospitals that increased recently in the HIIN, and like I said, across Iowa, South Dakota, and Illinois. We do comprise approximately 80% being critical access or rural hospitals. So I think that's a key thing to keep in mind too, is that we are mostly critical access or rural hospitals.
Okay, moving into our initial opioid guardianship project that we did. This project started in June, and it was a rapid cycle quality improvement project. That was a 4-month project. We did learn from that we did need to go ahead and make that a 6-month project. So you'll see on the timeline that is one thing that we did learn from our first project. So this is a geomap to show you who did participate. And it was very interesting to see that when we offered the first project out that we just, asked who wanted to participate, but we did see all over the state that everyone thought it was important. It wasn't just a section of the state, or it wasn't just critical access hospitals or PPS hospitals. It was a mixture of many types of hospitals, and then also covering the state. So this is a really good indication. So take a peek if you were not on the first cohort, see who's around you that really has already walked in the steps that we're going to walk in here going in the future. This is a list of the participating hospitals in the initial cohort. And once again, this will be recorded so you can see these slides again, and it will be put on Innovation. So if you don't have time to look at it, this will be recorded so you can see it again. I wanted to go over the data requirements for this project because we know that data-driven projects are ones that are most effective, and that's what we're looking at. So the first one is the adverse drug event rate, the number of acute care, swing bed, observation, adverse drug events. This is looking at how many drug events that are happening, adverse drug events, according to the NIC-MIRV scale, categories D through I, and it's over the number of observation patient days. So when we look at this, most of you are already reporting this, and we're also going to see some data to see what happened with the first project here in a minute. The second one that we're looking at is the number of patients discharged from a hospital on opioids with patient-specific goals of therapy at discharge. And when we looked at this with the original cohort, we were like, oh my goodness, what does that mean? And you guys are really going to see as we work through this, it means a lot of different things. It means, do patients know where to dispose their unused medications? Do they know how to taper? Do they have a realistic pain goal? Do they feel confident that they know who to call? And do they know what happens when they're having an adverse drug event with an opioid? Do they know what that looks like? So we came up with a lot of things, and you will as well as you work through this project with your patients. But really the denominator is really good information. So the number of patients discharged on opioids. This is really surprising, and I just met with a hospital yesterday, and they were talking about their patient population that they were going to choose to sample in this, and I had them guess, what percentage of those patients do you think are going home on opioids? And she couldn't hardly wait to get out of the room to go and actually review to find out how many actually are, because she did make a guess, and I can't wait to hear what it was. But this alone, if you do not have a treatment plan in place, which you may not, for a few months, and you may be working at this, but this number right here, this denominator, this is going to give you more information. And really, when we look at the goal of this project for less opioids prescribed, this is where we're really going to make a difference. Again, this is self-reported. The next one is looking at stat naloxone in the inpatient population. So this is not the ED, this is how many times naloxone is given on the inpatient population. Once again, self-reported. This is a measure that is already on our website, and you guys are probably using in our database. The one that we will add for you when you participate in this is the stat naloxone administration in the ED. This is really important because we're looking at how many times in the emergency department are patients getting naloxone. And, you know, what we found with this is some patients, it was end of life, and they were just seeing, you know, if the naloxone would work, and that's fine. But I think what a lot of hospitals found, which was really interesting, is, and actually this was just from another meeting that I had from someone, they found that when they kept track of this and found that the patient, you know, overdosed from heroin, they did do a deep dive, and they went back and they found out that it's from prescription medication that it's happening. So this is really important as we go back to our data slides on the increase of opioids and the increase of heroin. It really does go hand in hand, but we do need to do a deep dive to make sure, where did this start? Did it start from a prescription medication or did it start from street drug use? Because that's very vital information to this project. So just some information here. When we look from our last project, you can see that we did take data with a baseline of January through December of 2014, and then we moved up to present of August. So this is a really good, and give yourself a round of applause, because you can see that we did decrease our ADE rate since 2014. So first of all, I just want to say that is amazing, but I want to show you what happened. So even though our ADE rate is decreasing, look what happened to our stat Narcan administration in the inpatient population. Same timeline, you can see that it was very low and we did have an increased rate here. So the need for this is, you know, not only on the ED side, but also on the inpatient side. I wanted to share some survey results. When you do participate in this project, you will be doing a pre and post project survey for us, so we can, you know, not only see what you guys need, but moving forward to see how we did and what other resources we need to provide. So one of the first questions we asked is, what percentage of your inpatients discharged on opioids have a pain management treatment care plan? So I like to look at this to see, not sure, that was major or none. That was pretty much our answers. But by the end of the project, you can see the blue line. We really had some people that, you know, were to the 76 to 100% or above 50%. Just a few were in the none and not sure. So we do take that as a very big win, and we will move forward with that. How are you in educating your patients about realistic pain management goals? You know, this is really new verbiage for a lot of people. And you can see pre-project, you're using the whiteboards, initiating on the treatment plan. But I think the biggest win from this one, when I look at this, is you can see the blue post-project. There was some initiation of the treatment plan, but also into discharge planning. And we do have a resource that I think this is really going to take off in this next project. And I would like to say at this time, if you did participate in the first project, we are really asking you to stay on as experts for the second project and help answer questions on innovation and move forward, because as you know, if you participate in the first project, it hasn't ended. You're still moving forward and still sharpening the skills that we worked on in our first project. How often do your providers or other hospital staff access the prescription monitoring program database prior to providing opioid prescriptions? You can see pre-project, it was mostly never, or I'm not sure. But we did move into the post-project with more people doing this. And Sarah, you know, you can jump in here too, but we do work closely with the Iowa Board of Pharmacy, and there's not an availability yet to track physicians. So this is really hard. But I think what this brought up was a lot of conversations. When I do meet with a lot of hospitals, a lot of people don't even know what the prescription monitoring program is. And Sarah, do you want to just give a little update of what you know about the new system that's going to start in April?
Yeah, so the Board of Pharmacy is currently evaluating their request for proposals, and I believe they identified a vendor to do their new system. And this is hopefully going to launch early April, I believe April 12th of 2018. This system is going to have a lot more capability. It's going to be much easier to utilize, much more streamlined. You will also be able to register online, and if you forget your password, you don't have to call the Board of Pharmacy. They can actually have a link on there where you can do the forget your password and actually figure out your password. Additionally, they're working on having registration online for any of your agents or those who are helping you with the prescription monitoring program. So each physician can have up to 6 agents that can help them with this. And then lastly, I think the most exciting piece about this is the board is actually going to have the capability to pull reports around more of a regional or a local area, how many physicians are utilizing the prescription monitoring program, how many are registered. It's just going to give us a much broader approach to reporting on what is actually happening with the prescription monitoring program and which communities do we need to help get more use out of the prescription monitoring program. So we're very excited to see what that's going to bring. And again, that will probably be around April of 2018, but we will keep you posted during this project on exactly what is happening with the PMP at the Board of Pharmacy.
Thank you, Sarah. Okay, and another one, does your institution provide or participate in education or awareness for your community about the safe and effective use of opioids? You can see here, this was a really big win. A lot of I am not sure's or no's, but we did have at the end almost 90% that did do some community education. And what we are going to provide in the second group or cohort, you'll see, is a train the trainer. So we're going to put together slides with words to say. You can add your hospital specific information and you can utilize that to feel confident that you are giving your community the right information, and that also will help with expectations from patients when they come into your facilities. And lastly, but definitely not leastly, do you know where the medication drop-off for opioids is located in your area? And this was 100% successful, and we will continue with this. Like I said, we will be working with the Iowa Board of Pharmacy and IPA to go ahead and get this information to you, make sure it's correct. We'll make sure that phone numbers, dates or times of the locations that they're opened, and everything is available for you when you participate in this project. Some tools that came about during this project, this is really exciting, and these are receiving a lot of national attention right now. But as we went through these tools and worked with many hospitals, we did have person and family engagement at the forefront of this. And so when we look at each tool engages the patient to think about their comfort level. So we're moving once again from pain to comfort and asking them, you know, how can we help you get comfortable? And when we move forward to look at our titles, everything does switch to comfort from pain. We provide an action plan on when transitioning home. You'll see one of our resources. It is a treatment plan that you can actually use right away. You can change whatever you want. We have these all available in Word documents. So that's another thing that we learned. We had them in PDF, and a lot of hospitals were having a hard time, so we did change those. So you can go ahead and change them as you use them, and you'll see as we go through these resources. But I think one thing that I really like about this is this empowers the patients to ask questions. What we found, and I think we can all agree, that if we ask most patients, are you taking an opioid? And they may be on Percocet, they're going to say no, they're taking a pain pill. But they don't make the relationship between opioid. They're scared of opioids, but they do not understand, and it's our job as healthcare providers to help them to know what questions to ask. So our first resource that we did come up with is a comfort scale, and we're going to talk about this here in a little bit, but this is really a big push forward. We've had the pain scale for years and years, maybe 100 years plus, but they've really never been proven to be effective. And so this may not be our final comfort scale, but this is our original one come up, and during the project, you will have the opportunity, and it'll be actually one of your commitments, that you will utilize the comfort scale in a section of your population for patients. And we can go ahead and move forward to try to get this published. So we'll talk more about that when that comes closer in February. Another one that we came up with, and this is working with Broadlawns, is the comfort menu. So when we look at the comfort menu, we see that patients actually have input to say, what makes me comfortable? What personal care things and comfort actions can I actually do, or how do I relax? So this, you can have your nurses. I know that I'm just going to say Community Memorial, I'm really proud of them because they have this in every single section of their hospital. And what they did is they took it to their frontline staff and they asked them, which of these items do you want on here? So your patients, when they do hourly rounding, they can say, did you look at your comfort menu? Is there anything I can get you from your comfort menu? And then Sarah and I took a lot of time down the medication column and also at the top to make sure that this was in line with the CDC guidelines and also Joint Commission standards that come out in January. And so when you look down these, this really encourages the patient to discuss. You can see the word discuss, depending, you know, when you see the words that are going on here, this really encourages the patient and family to be part of the healthcare team. We did go ahead at the bottom of that medication column and make sure to not shame anybody. So while opioids have their place, they should be started on a low dose and stopped as soon as possible. So we did put that there. So we do want to realize that, and our patients to realize that opioids, they are a good medication when used in the correct way. So again, this will really go to alternative methods. So when we look down here, it doesn't mean you're going to use all of those, but there's some options. The next one is the post-op comfort plan. When we look at this, you can use this as a treatment plan. It doesn't have to be post-operatively. It could just be the opioid comfort plan. So when we look at this, we do have those words popping up again, the realistic comfort goals. We have the comfort scale listed. We do have options for improving my comfort level. So while they were in the hospital, if they found out that using another pillow made them comfortable, they can write these down and they can know what helped, and they can actually go home with a comfort level. I know that some hospitals are using it before surgery. They're filling this out and actually taking the comfort menu home to find out what makes them comfortable. They're using it in the hospital, and they're also using it for follow-up in the clinic and also with a follow-up phone call conversation. So this is actually a piece of paper that can follow them the whole way through. Once again, the very important part of this that I really, really like is the patient engagement part that says, you know, this is why am I taking this medication? Where do I dispose it? After how many days? How about tapering it? It just asks the questions that maybe they don't know to ask, because we all can agree when we go into a patient and we start saying, do you have any questions? I would say, you know, 75% of the time you're going to get a no, because they don't know what questions to ask. So we are assisting them and encouraging them to be part of their care plan. And then once again, what we found is a lot of people don't know who to call. So you can have the primary care provider, you could have the surgeon. Again, you can change it to what you would like. And then most importantly, we do have the conditions of an adverse drug event that's happening if they are taking an opioid, and when to call 911, because that is a medical emergency. And then our last resource that we did put together, and I talked about this, was the disposal site and treatment resource. So you can see I just used an example of Avera Holy Family Hospital, and it has their drop-off sites with hours. It also has their treatment facilities that is closest, and then who provides the standing naloxone order. So this will need to be updated by each facility. I think we suggested every 6 months that they just call, make sure the hours are the same, make sure they're still open, and do a check. But we will be doing that again with this project for new people, and then also for the first cohort that went through, we'll be making sure to update their resources for them. But this is a great information sheet that all patients should have when they go home.
All right, so next we wanted to talk a little bit about the commitment of participation and what we'll need from you to be a part of this project. First and foremost, if you do wish to participate, please email Jennifer at the email on the screen by January 5th of 2018. So that only gives you a couple of weeks, but we want to make sure that you email Jennifer if you are interested in participating. If you send her an email, please include your name and your contact information and what facility you are at as well, so that she knows who she is working with. Secondly, we will ask you to identify an executive sponsor to support your participation by January 18th of 2018, so about a month. The reason that we want to have the executive leadership or your C-suite, whoever that may be, on board is we found that those who do have their executive group on board with this are actually much more successful and can be much more nimble and can move more quickly with this project. So that is an absolute requirement of this project, is that we have somebody in the C-suite or in that executive area actually sponsoring it. Additionally, we will ask you to assemble an opioid guardianship project team. This team will help your facility to be successful and to make sure that they are actually action-focused throughout the different phases of this project. We do expect that the facilities participating do hold team meetings at least every other week so that things don't drop and things can continue to move forward. Another commitment will be submitting required self-reported data to HIIN on the database around your adverse drug event measures. So that is a requirement that we are adding to this cohort. We also require the completion of a pre and post survey by the deadlines, and we have those on our flyer and on our timeline, so you will see those deadlines, and we'll be able to remind you of that if necessary. We have shared successes and challenges with cohort colleagues throughout the project. So as Jennifer mentioned, we are pulling that first cohort back in and asking them to help guide our second cohort and answer questions, or really give them your success stories so that they can continue to move forward. And those in the second cohort are able to share their challenges and what they're really struggling with, and then the first cohort can really help them through. We do ask that at least one team member participate in each of our 4 webinars, and those again are on our timeline. The utilization of the comfort scale and the sample population is required to participate. We are going to be doing a translational research study, which looks at the impact of the comfort scale so that we can actually get this published and show that it is an impactful thing that we are utilizing. And that is a great opportunity for all of you to not only participate in a research study, which IHC will be really running in partnership with Drake University, their College of Pharmacy, but it's also a great opportunity for you to potentially have some national recognition once we do publish this. And I can tell you right now that we have several other HIINs and several other hospitals reaching out to us asking how they can start the implementation of an opioid guardianship project at their location. So this will be a very important piece to make sure that this comfort scale is actually impactful, and we already know it is. We just need to have formal research done on it. And then providing community outreach is going to be a key piece on the safe and effective use of opioids. So as Jennifer mentioned, we do have a train the trainer portion where you will have the slides, you will have the verbiage, and we will train you on how to go out and actually talk to your community about the issues around opioids and how to use these medications correctly. The exciting thing with this is it could be your pharmacist, it could be your physician, it could be a nurse, it could be an MA, whoever is super excited about this can go out and do this presentation and go out to the different community groups to actually share this with them. So it's not something that you are required to do in your hospital or anything like that. We really encourage you to get out in the community and start sharing some of this work. So team formation, you have heard us say this time and time again today. The team formation is really going to be a key piece for you to be successful in the Opioid Guardianship Project. And we do think that these members listed here are really the key members to have. We encourage you to include others if you feel that there's somebody at your facility that should be included, but we need to have that physician buy-in. We need to have our quality people on board with all of this so that we actually are getting the data that we need and that we're seeing that data move over the course of the project. Again, that leadership or executive sponsor is going to be absolutely integral to make this project successful. Your pharmacist is one that can be really helpful with not only data, but also helping you learn how to implement different pieces. The pharmacist is very knowledgeable, they're very excited, they want to be a part of this, so please, please, please include them in this. Your nurse manager is going to be a very important person to help make sure that this is being pushed out correctly to the nursing staff and to really be that touch point on, do we need to change something on our comfort menu, or is there something not going well that we need to look at? Discharge planning is of course going to be a key component of this so that we do have that treatment plan being sent home with the patient, and having them educated to do that is going to be very important. Again, that frontline staff is going to be the ones actually implementing this. So they absolutely need to be a part of the team and know what's going on and can share what's working well and what we could improve upon. IT is something that we have found to be an important piece as they start to integrate some of these resources into the EMR, and that way it makes it easier for all of you to do your job. And then of course the patient or family member is at the center of this team, and we want to make sure that they're engaged and understand why we're doing this project, what they're going home with, and how to properly utilize those opioids. So let's take a quick peek at our timeline here. So we will be requiring commitment with that email to Jennifer and the pre-survey due around January 5th. Our first big webinar will actually be on January 18th, and we'll give you a quick sneak peek towards the end here, and that will be on legality around opioid practice. On January 31st, we will release the why and how about the prescription monitoring program, and this is actually a great pharmacist, Randy McDonough, who is in practice in Iowa. We'll be speaking about how to utilize the current prescription monitoring program, and we do have nurse contact hours available for that. February 15th, we will have our second webinar, and this will be looking through a new lens from pain to comfort. I do want to add that this will be the point that we will release some of those comfort items and expect you to take them and run. But some of these webinars, especially our first and second one, may be anywhere from 60 to 90 minutes. They will be recorded, so you can always come back and view them. But do know that they may be a little bit longer because we have a lot we want to cover with them. Again, on February 15th, that's also their official launch of the comfort resources. February 28th, we will release our Train the Trainer education on how to execute a community meeting. March 15th is going to be our Upstream prevention, tools and best practices. So we will be looking at how to utilize the different tools that are available and talking through some of the best practices. Again, nursing CE or nursing contact hours will be available for this webinar. On March 29th, we will have our third webinar, Breaking Down the Silos to Mobilize Your Team. And that will be a great way if you're starting to have some challenges in keeping that team together and keeping everything organized, to really come back and take a look at how we get that team going and continue with the project at that March date. April 12th, we have the Untold Stories of Diversion, and we have some speakers in mind that are going to do a wonderful job of sharing actually how diversion happens, not only from a community level, if patients are taking their medications from other family members, but also looking at healthcare professionals and how diversion could potentially be happening and how to recognize that. And again, nursing contact hours will be provided there. May 3rd is our fourth webinar and our final one, which is patient-centered care, monitoring and disposal. So this is really focusing on how do we properly take care of our patients and how do we let them know how to dispose of these medications so they're not sitting out in the communities. On May 17th, we will have addiction identified, now what? So what do you do once you do find somebody has opioid use disorder? What's the next steps and how do you really reach out to help them? And again, that will have nursing contact hours. On June 10th, the post-survey will be due. And then June 21st, we will have a project review webinar to share the results that we found not only with that survey, but with the data as we went through this project. And then finally, on June 21st through July 21st, so that last month at the end of that project, we are asking for each of the hospitals to do a virtual meeting to discuss data and project review. We did this with our first cohort, and it was invaluable to us to set up this second cohort. These meetings truly helped us understand where the challenges are, where the successes are, and what we can do here at the Compass HIIN to support you as you work through this project.
Okay, moving into action items for success. Firstly, let's go ahead and have you send a commitment email to myself. And when you do this, if you know who your owner or your executive sponsor is, please email that. If not, you can be working on that and let me know in the future. When you do send me a commitment email, you will receive an email back with some things to do, and then also the survey, so you can go ahead and find the right answers. And talking about that real quick, the survey, if you do not know the answer, we really would like you to reach out to the right resources to try to get as much of a correct answer as you can. So once again, form your opioid guardianship team. And I think when you do this, you'll be really interested to see who will want to be on your team. There's people that do want to join. And when you put something out there, like I said, it may not be the person that you expected, but if you get someone with passion that really wants to work this project, that will be very helpful to your team. Ensure your quality improvement efforts are driven through data through reporting the required HIIN measures. So work with your quality to make sure that you understand what the definitions of the measures are and how you can assist in getting that information to your quality personnel. And you can also ask for a run chart to see, you know, what's the history? What have we been reporting? What have our numbers look like? And then also to join and participate on Innovation. If you are not part of Innovation, this is our platform where we have a lot of resources. This is where I will put any email communication to the group. You will see, I will put that out there. Also, I will be putting the recordings out there to every webinar that we do. You can also see the timeline in the flyer and any other documents that we put out. This is where just a one-stop shop where you can do that. The other nice thing about Innovation is we do have many pharmacists, many quality people. We do have some physicians. We have frontline staff on there. So as you're working through this project, this is really the hub to ask questions and to bring up successes. Like Sarah said, with just not only challenges, but if you do something that really works, share it because you could help someone else. And then I already talked about the survey.
All right, so mark your calendars for our first webinar on January 18th at 11 a.m. We are actually going to be talking about legality around opioid practices. And Jennifer and I found that this was an important topic to really engage those different prescribers to understand why this is so important. So we have two attorneys coming to join us. Our first is Craig Sieverding, and he actually has a great background in regulatory and what that looks like. So he's very knowledgeable about the Board of Pharmacy, Board of Medicine, Board of Nursing, all of the rules and regulations around practices when it comes to opioid prescribing, utilization of the different tools. So he's going to share his knowledge around actually that regulatory standpoint and what you should be doing to make sure that you're not breaking any of those rules or regulations. And then Adam Zenner is an attorney who actually worked on the Dr. Bali case here in Iowa. So if you're familiar with some of the Dr. Bali case with some of the diversion and different things were happening, he also worked on the large pharmacy case that had the largest opioid diversion in the United States. So he is going to share his perspective on what to avoid, the different points of areas where diversion may be happening, why physicians may be questioned about their opioid practices, and then what you can really do to prevent getting into that situation. So we are extremely excited about this webinar. Both of these attorneys are very, very knowledgeable. They've worked on several different cases and different regulations and can share a great deal of knowledge with us. So we are confident that this one will probably be closer to a 90-minute webinar just because of the amount of information that these two men have. And with that, we are happy to take any questions that you all have. We've got about 10 minutes left. You can go ahead and use the group chat function. We have also unmuted your lines. So if you do not have your own line muted and you do not want to be heard, please feel free to go ahead and mute yourself. But we are happy to take any questions, and we will allow a time for you guys to do that right now.
Questions about that? So don't enter a ticket.
And again, if you do not have your own line muted on your phone, I suggest you do so unless you would like to ask a question.
Oh, don't take too much. Take credits, that's a lot.
And you can take back to the physician advisory council about what's being done with that, or if you want more information from folks on the phone.
No, I'm on the call every day. I know exactly what's being done. I'm just not very...
Okay, well, we're going to remute all our lines because we have some people that I don't think realize they are speaking on here, but please feel free to use the chat box. I know Jennifer and I have heard from several people that are interested in the project. We've also heard from several people with different questions. And so if you do have questions, this is the time to ask them so that we can share the answers with the group. But you can also feel free to contact us. My email is up there as well if you have specific questions afterwards. And then Jennifer is the one that you will want to contact if you're interested in participating. So we did have a question come in, and the question is, what have others found is the best way to find the required data? Do you use the EHR or other methods? And I'm going to pass this to Jennifer since that is really her world.
Yep, Tasha, thank you so much for that question. That is a question, anytime I see EHR, I smile because this is something that we deal with in the data world every single day. Is do you pull it or do you abstract it? And it kind of depends on which system that you're using. So we will start conversations around that on Innovation because people do it different ways.
And another question we had come in is, do we have to post a sign in the ED that we are participating in the prescription monitoring program? That is not a requirement that you post that in the emergency department. I do actually suggest that you have something posted to say that you do check the PMP or that you do utilize opioid prescribing habits very judiciously, just so that those patients that may be medication seeking are aware that this is a hospital that does utilize some of those resources. Our next question is, would a same-day surgery area be appropriate for a unit to trial the comfort scale, or is this inpatient unit-based only program? And I'm going to make a couple of comments, and then if Jennifer has anything to add, I'll turn it over to her. We actually saw really great success with those that had surgical areas. So I think a same-day surgery would be a great place to start, and not only looking at the treatment plan before they have their surgery, so maybe at that pre-op appointment, after their surgery, and at follow-up. That's probably some of the bigger successes that we have seen. If you would like to try it in an inpatient unit, absolutely. We do suggest that you start with one unit and not necessarily try to do the whole hospital, as that can be quite overwhelming to try to take care of all different units as you're putting this into place. And we also suggest starting with one area specifically because you can kind of see where those challenges are and work out the kinks before you do a larger rollout. Do you have anything to add, Jennifer?
Yep, Sarah, I agree with everything that you just said. And I would just add, as your team grows and as this project moves on, you'll see some hospitals have their EMS using the comfort scale, their long-term care facilities, their clinics. So I think that what we did see is when you try to do it all at once, that's really hard. So once again, just to reiterate what Sarah said, let's start it in one patient population. Let's get the process down and then move it out.
And I would just add off of that, as Jennifer said, we're seeing it in the long-term cares and in the clinics of those communities that have already started this in the hospital. So I know that we are very cognizant of that and starting to work through the different programs we have here. We do have the Transforming Clinical Practice initiative here, which is through the Compass PTN, and that is something that I'm starting to work with those local clinics to make sure that we actually push out our comfort resources so that those prescribers are aware of it and not surprised when a patient comes in with these different comfort pieces. And then we will be working with the communities through that train the trainer piece so that patients are educated on what this is and why it's important. So know that we are working with those other areas. It's just taking a little bit longer to roll that out since we wanted to make sure we hit the hospitals hard when we first started with this comfort information. And again, if you do have questions, feel free to add them to the chat. We do want to be respectful of everybody's time, so we probably have about 6 or 7 more minutes here if you do have any questions. And we'll give folks just a couple of minutes here to see if they can add anything to the chat. Okay, we're not seeing anything come in here. I do want to thank you all for joining us today on our really introductory webinar to our Opioid Guardianship Project Take 2. We are very excited to hear from all of you, and we look forward to seeing who's going to join us and participate in this. We know that this is going to be a very impactful project for you all to work on. So we're excited to work with you on this. We did have a question come in saying, can hospitals that participate in round 1 also participate in round 2? And yes, absolutely. As we covered here in this webinar, we definitely suggest that if you are from the first cohort, please join us and help the second cohort through. I think it will even be beneficial for that first cohort to actually talk with the second cohort, and they may identify some successes that they could implement into their own hospitals. So we are hoping that the first cohort really will join in on the Innovation chat area and really start sharing some of the successes they had and answering those who do have challenges and helping them through those challenges to help implement what worked in their facility. So we're very excited about that. Another question came through, will these slides be available to share? Yes, we will have them up on Innovation. So you will have that as well as a recording of the webinar today. So absolutely, we will have these available for you to view. And it will be next week, so give us a couple of days to get that going on there. We're just checking to see if we had anything else come in since we had a couple more questions here. Okay, we're not seeing anything at this time, but if you do have any questions, please feel free to contact us. We are very excited to get this all going, and we look forward to partnering with all of you to continue to combat this crisis in Iowa. Have a wonderful holiday season, and we will talk to you all in January.